Good evening. It's my pleasure to introduce tonight's speaker, Dr. Martin Shapiro. Over the last year, I've been very fortunate to serve on a steering committee of a research fellowship in health disparities with Dr. Shapiro. And so in a moment, I'll tell you a little bit of my personal impressions of him as a human being and as a colleague. But in order to introduce him, I needed some knowledge of his biographical information. And so I wasn't super familiar with that. And so I asked ChatGPT to write an introduction for us. Now, I know this is like getting to be a sort of a stale joke, but I hope you'll humor me a little bit, because I think it's a great example of using super high-tech chainsaws to cut butter, much like many of the examples in Dr. Shapiro's book and his approaches that he advocates. A lot could be gained with much simpler techniques, and a lot is wasted with such crazy techniques. So let's see how this works. According to our future overlords, Dr. Shapiro was born in New York City and grew up in the Bronx.
Not true.
I don't know if this is true, but I will say that it fits with his personality and some of his references. But I suspect that it wasn't true because more trustworthy sources tell me that he earned his bachelor's degree of science from McGill University. So I suspect maybe you grew up around Montreal or in Canada. Our computer guide continued to tell me that he received his bachelor's degree from Columbia College in 1965, his medical degree from the Albert Einstein College of Medicine in 1969, and I knew that both the locations, universities, and the years were all nonsensical. Especially because the book describes his medical training at McGill University in Montreal, where he earned his MD. ChatGPT then says, after completing his residency in internal medicine at the University of California, San Francisco, he pursued a fellowship in health services research at the RAND Corporation in Santa Monica, California.
Wrong.
That is my favorite part. I would love to see some of these ideas in a RAND Corporation. No, this isn't a real man, but I would just love to see some of these ideas in RAND Corporation pamphlets. That would be wonderful. But in fact, Dr. Shapiro did his residency at Royal Victoria Hospital in Montreal, and at UCLA, where he added a Master's of Public Health to his vita and a PhD in history, focusing on healthcare services in Portuguese Africa. This latter detail for me explains the scholarly and wonderful format of his book, echoing Socratic dialogues and full of wonderful context and cultural references. And it also reminds me of a running joke that circulates in history departments, that the study of colonialism is automatically radicalizing. I was prepared to make a joke about the study of healthcare delivery, but now I know that Martin must have been predisposed to seeing inequity and exploitation in the public sphere, probably long before he earned his MD. So I won't take too much more time. Dr. Shapiro has a long and accomplished career as a medical educator and practitioner. In his first faculty position as professor of general internal medicine at UCLA, he established their primary care research fellowship and later served as chief of division for 25 years. He's now a professor of medicine at Weill Cornell, published over 300 papers on health equity and healthcare delivery, particularly in issues related to underserved communities in their battles with HIV, cardiovascular disease, and literally dozens of other issues. He has studied the impact of co-payments on necessary medical service, inequities in health among insured Americans, scientific misconduct, quality and accuracy of pharmaceutical advertising, and many, many other social and cultural aspects of the delivery of medicine and healthcare. He's been the recipient of scores of awards and honors, most notably the Herbert Nickens Award, recognizing his commitment to cultural diversity in medicine, and the Public Policy Impact Award from the American Association for Public Opinion Research. I wasn't able to find any statistics on the number of trainees Martin has had, but my guess would be that there have been many, and their accomplishments are probably his biggest source of pride. In the year or so that I've known Martin, I've come to know him as a deeply caring mentor, a highly aware and pro-social analyst of American society, especially as it concerns health and healthcare delivery. As you'll hear tonight, Dr. Shapiro is incredibly woke in all the best senses of that word. Reading his book has awakened me to many of the problematic issues in American healthcare and biomedical research, even though I already thought I knew what was up. I've been deeply moved by the personal details and the stories of patient care, and I've been filled with despair at the many, many factors that continue to push our system in the direction of more expensive, less fairly delivered, and just generally worse medical care. But I was also buoyed by many of the solutions Dr. Shapiro puts forward to create change. He calls them quixotic, but I pray that it's not just tilting at windmills. I think it will make real change if people start to absorb some of the messages in his book. I hope you all enjoy his talk as much as I enjoyed reading his book, and I'll turn the floor over to you.
Well, thank you very much. I'm overwhelmed to learn all those wonderful things about my career at UC San Francisco. I did spend some time at the Rand Corporation, but I wasn't the one who designed the doomsday machine. I can assure you of that. So, well, but thank you for that very generous introduction, and it's been a delight to work with you and others here in New York. I entered academic medicine, like many others, with the belief that producing evidence on the shortcomings of the system would lead to their amelioration. But we fell short of that aspiration, and with my book, I hope to engender serious discussion about how to get back on the right track. And in writing it, I had no difficulty enumerating problems in many domains, but it became apparent that these problems were not just incredibly bad luck, they must be linked. To understand why that might be, I considered my experience in clinical practice, education, and research in the context of evidence and theory across multiple disciplines. So I learned a lot. It took a lot longer than I expected, and the process was humbling. I was motivated by the belief that if pre-med students, physicians in training, practitioners across multiple specialties, and leaders of organizations acting in the health sphere were exposed to such ideas and were to consider them, it might engender some humility about American healthcare and shake some of them out of their career-driven complicity and complacency. Oh yes, this is the device. It works. So I have no financial conflicts of interest to declare, but I must acknowledge that I'm a physician, I'm a Canadian. I have strong feelings about equity, and when I was younger, I used to wear a button that proclaimed that criticism is an act of love. Well, for many, it's a great time to be in healthcare. It's a time of scientific breakthroughs. It's an age of exploding knowledge of the mechanisms of disease. It's an epoch of extraordinary profits for corporations in the health sector. It's a season of life-saving medical interventions. It's the spring of personalized medicines, and some believe we're going to approach immortality. But is that the whole picture? It's also a time of clinical neglect, of blissful ignorance towards chasms in health, of personal bankruptcies due to medical debts, of choosing between paying for health care and other necessities and basic needs, like food, clothing, and housing. These personalized medicines can cost tens of thousands of dollars for a person in a year. And it's the winter of avoidable deaths for those whose problems lack priority. Immortality certainly isn't a preoccupation of those facing premature death. So why is it so hard to fix healthcare in America? I believe if we're going to make headway, we need to think about it in a different way than we have up till now and act accordingly. What is rotten in the state of healthcare, I think everybody here knows. Disparities in access and health, high costs, and poor outcomes are three enormous problems. Lack of insurance for many is a huge problem, and underinsurance for even more. Our health expenditures far exceed those in other countries as a percentage of gross domestic product. Back before 1970, the US wasn't such a spendthrift. Numbers were comparable to those in Canada and other countries. That changed when Canada adopted its national health plan. And over that time, the US has steadily fallen behind other countries with advanced economies and life expectancy. At 78.9 years before the pandemic, we lagged other European countries by 3 to 5 years, and that's even gotten worse since the pandemic. So why has it been so hard to pull the right levers and create policies to solve these problems? I believe the problems are multifaceted and go well beyond the targets of policy proposals and research, really, and the ways in which various groups of actors conceptualize health and healthcare, pursue their interests and perceived needs, and interact based on these conceptualizations, create impediments to a system that is rational, just, and efficient. Let's look at the groups of actors that I argue all stand in the way of equitable, efficient, and effective care. Physicians and their organizations, medical schools and universities, corporations providing care, including hospitals, health systems, medical groups, pharmacies, nursing homes, and dialysis companies, other corporations in the health sector, those who manufacture stuff, health insurance companies, investors, but also scientists and their organizations, government, employers, and patients, their families, and employee groups in many community organizations. I think three phenomena shape the circumstances and experience of healthcare in contemporary society: the treatment of healthcare and health itself as commodities by all actors within the system, the consciousness of the various groups of actors, their attitudes, values, perceived needs, expectations, interests, and capacities, which condition their conceptualization of health and healthcare and much of their behavior in relation to it, and the nature of communication and relationships among these groups of actors, which reinforce the existing arrangements and impede change. Luis was a 23-year-old man from Central America with a mild learning disability. He lived with his parents. He had congenital immune deficiency that had required immunoglobulin infusion since birth. Early on, he developed hepatitis C from an infusion. When he was 7, his parents moved to the US and he came to my teaching hospital for his care. We took care of him for 15 years. Meanwhile, the hep C progressed to end-stage liver disease. The liver transplant service declined to list him for transplant, saying that he had no insight about his illness. His parents both worked, so he didn't take meds consistently. They believed if he were transplanted, he wouldn't reliably take the medicines needed to prevent rejection. My residents and I sat down with the family to discuss his situation in Spanish. It turned out that he'd never missed a single dose of medicine. Because of his illness and disability, his loving parents had chosen to work different shifts so that he was never alone if he needed medicine or became ill. He also did understand his illness and the importance of taking his medicines. At his bedside, one couldn't help but notice the family dynamics. His parents were totally devoted to keeping him well. Without the procedure, he was going to die. We shared this information with the liver team. They pointed out that he was an undocumented immigrant and that while coverage was arranged for his routine care, he didn't have insurance to pay for the procedure. I spoke to the liver transplant surgeon, noting his history. He'd been there for 15 years. He said he'd waive his fee, but we'd have to get the hospital to cooperate as well. The associate director of the hospital, which ran annual surpluses of about $200 million a year, told me that it was a considerable expense to do a transplant, and even if they waived all charges, the patient wouldn't be able to pay for his transplant medicines in the long run. I implored him to pursue it and see if California's Medicaid or others would provide some coverage, given his long history living in the country. He claimed they tried, but Medi-Cal refused. We were very upset. The hospital's decision was final. Our only hope was to get him to another hospital that might try harder. Fortunately, a hepatology fellow was as frustrated as us, and he found another program in the region that was willing to take him. We learned that they were able to get the procedure authorized, and he was placed on the transplant waiting list. So Luis's story illustrates many salient issues. Notwithstanding an apparently acceptable outcome, the system had failed him. Even though we showed that he'd be able to take his medicines consistently, that his parents were very supportive, and his time in the country should be mitigating, he would have been sent home to die. In American healthcare, some lives are cheap. In cases like Luis's, the problem isn't only the tunnel vision of docs who fail to collect vital information, but also the priorities of health systems, including America's so-called best hospitals. A far from acceptable quality of communication with patients and families also can stand in the way of patients getting the care they need. So my main point today is that fixing healthcare is very difficult because of the interplay of consciousness, the commodified world of healthcare, and the toxic relationships and problematic communications that pervade it. Resolution of these challenges requires acknowledging this interplay and addressing it. all present some approaches to the problem I identify, but few, if any, will come to pass unless we broadly address these phenomena that undermine progress. Let's consider the groups of actors in turn. Major health systems include the ones that are academic and non-academic, and those that are for-profit and those that are supposedly not-for-profit. The behavioral distinctions aren't clear. And they contribute to the problem in a number of ways. Early in my career, my department had a retreat, and this keynote speaker was a senior exec from Henry Ford Hospital in Detroit who told us about their business strategy and how they increased sales. Then he paused and said, which you refer to as hospital admissions and outpatient visits. That was clarifying. Far too often, these hospitals maximize market share of covered lives, maximize reimbursement for services, minimize risk, meaning poor people with Medicaid or no insurance, contract with healthy populations to develop and promote lucrative product lines, prioritize expensive procedures, make deals with industry, strive for 9-figure surpluses, and reward executives with 7 to 8-figure salaries, of which 30% nationally are performance-based bonuses. Two of the major academic systems on this island, CEOs earned over $10 million in 2019. I keep pushing the wrong button. So, can you alter these incentives? I think changing the behavior of these corporations is a steep hill to climb. But we could start by not paying CEOs salaries 50 times what some of their doctors earn, and bonus payments based on financial performance, and require full participation of all clinicians in Medicaid for health systems to maintain their nonprofit status. Some other corporations in healthcare include those who produce goods, and they're interested in sales as well. The pharma and the biologic manufacturers advertise shamelessly to patients and providers, trying to convince the former that their products will extend their life or improve its quality without regard to how much or at what cost. They raise prices when they can, often recruiting academic economists to justify their price points. They extend patents with minor modifications, so-called evergreening, and restrict competition, and mightily struggle to prevent negotiation of prices. Equipment manufacturers manage to market their latest version of their products by letting it be known that competing clinical sites have done so, and fight hard against taxes on the products. Information system manufacturing is an oligopoly. Prices are prohibitive for small practices. They increase costs of care and the work of providers for benefits that may or may not be forthcoming. The health insurance industry sees public insurance as an existential threat and fiercely resist expansion of public coverage, but prod their allies in government to privatize the more lucrative components of existing public programs. They add to problems with the current system because they seek to minimize risk by denying coverage for procedures, offering products with large co-payments and deductibles, and they add greatly to administrative costs. Co-payments, deductibles, and denials are an enormous burden and saddle many with insurmountable medical debt. Other corporations like nursing homes and pharmacy companies are motivated to maintain and sometimes massively increase their revenue streams. As for investors, hedge funds have moved aggressively into the health sector, seeking to inflate apparent value through maximizing billing revenue, cutting corner, and then selling at a large profit. Some talk about value-based care, but when one was recently acquired by CVS, the value they spoke of was, quote, offering significant value to our shareholders. Gordon Gekko couldn't have said it better. It'll be interesting to see as they start to acquire more academic practices if the latter have come to judge those goals as incompatible with their missions. So when you think about all of these corporations, policy changes aimed at fixing corporate behavior are likely to have much impact without much broader changes. There are many wonderful docs, but practicing clinicians and their professional societies have economic interests that are quite obvious. The payment system reimburses procedures far better than evaluation and management. Inevitably, procedural societies resist redistribution of income to what they call cognitive fields by occupying 70% of seats on the committee which advises Medicare on fees. They often produce guidelines to justify their activity. They minimize risk by optimizing insurance, and they run the till as long as they can. When I was a young physician at UCLA, the residents used to joke that cardiologists there had only 2 indications for a heart catheterization, lub and dub, which is what doctors call the 2 heart sounds. So pretty much everyone met the requirement. The ways in which the health system pays for services shape the ways in which physicians practice, and income differences between procedural and cognitive fields are stark, and in fact have grown since the relative value scale was implemented in Medicare. At the same time, doctors are not selected into medical school primarily to be empathetic, caring, and altruistic. Many handle uncertainty poorly, aren't trained well to limit care, are more comfortable with narrow tasks like procedures than building relationships with patients. Accordingly, the choices that many make of specialties are driven by efficiency of income generation. Communicating effectively with patients isn't well rewarded and often is actively avoided. David was a medical student doing his 3rd year clerkship in internal medicine with me. He was very smart and highly motivated. His knowledge of disease and treatment was at a very high level. He interacted very well with members of the team and the nursing staff and was terrific with patients, sensitive, open, caring, and committed. He obviously loved what he was doing. I shared my impression. I told him I thought he'd be a wonderful resident in internal medicine. He told me he loved the rotation and could imagine himself in internal medicine, but that he'd been advised by other students not to do that. Quote, "Your test scores and grades are too good, it would be a waste," unquote. They were saying that his level of medical school performance would qualify him for a higher paying specialty. Nonetheless, he promised to think about what I'd said. The proportion of residents filling positions that are filled by U.S. medical graduates bears a linear relationship to specialty income. Several months after our conversation, David came by my office and asked if I'd write a letter for him for residency. I was happy to provide one, but was disappointed to learn that he chose to go into anesthesiology. I'm sure he'll be a terrific anesthesiologist, but his awareness of what it meant financially was a corrupting influence upon a career decision. So why doesn't society value cognitive fields more? Such work is no less complex and demanding and no less life-altering for patients. I can illustrate stories from my own practice in this regard. A patient who needed constant coaching and repeated discussions of evidence and emotional support to stick with treatment for Hodgkin disease. A person who was dying and in pain but needed to hear from someone whom he trusted that it would be okay to end active treatment. A patient with severe hypertension and a serious mental illness that made it hard to adhere to treatment and show up for appointments, who needed a doc who would stick with her and keep her alive. A patient who was dispirited by multiple morbidities and needed her doctor to manage her complex regimen, but also to keep her spirit up. So, can we change clinicians' priorities and competencies? Here are some ideas. Pay doctors for their time, not for piecework. Specialty pay should differ only modestly to account for differences in time and training. Incentivize clinicians to seek psychotherapy to help them better understand and relate to patients, their needs and values. All physicians should have periodic training in communication and negotiation with patients, and in ethics, morals, and social responsibility, perhaps sharing those latter classes with their hospital administrators. Mandate that procedural specialists and hospital administrators meet regularly to discuss strategies and set targets to reduce use of low-value care, rather than the opposite. How about educational institutions? Universities and medical schools have considerable interest in the status quo and are part of the problem. Medical school admissions are limited almost entirely to those with great GPAs and test scores, and pay little attention to values and ability to empathize and communicate effectively. Not surprisingly, the great majority of those admitted have studied the biological and physical sciences and related fields, overwhelmingly represent those from privileged backgrounds, and underrepresent blacks and Hispanics. Medical schools do a poor job of identifying students with commitments to social betterment that are more than window dressing on their applications. The undergraduate curriculum is science-based and biologically reductionist. Humanities and social sciences are at best an afterthought. There are white coat ceremonies on entry into medical school, supposedly about humanism, but they're really an exercise in triumphalism for people who've accomplished nothing yet, but have been told that they've arrived. And students go through a well-described negative socialization and loss of any idealism that medical schools don't show much interest in arresting. Once selected, students don't learn nearly enough about how to relate to patients, and next to nothing about ethical obligations and social responsibilities. Some who arrive purportedly intending to follow in the footsteps of Mother Teresa rapidly decide to pursue the highest paying specialties. And student debts can be substantial, but doesn't preclude eventually living in comfort, but it does provide a rationalization for such decisions. In postgraduate and clinical training, there are lots of wonderful docs, but it's the exception, not the rule, when faculty model judicious, evidence-based application of technology and commitment to diverse populations that might make America less exceptional. Again, there's little exposure to the humanities and social sciences and few opportunities to address doctors' personal challenges that stand in the way of effective relationships with patients, and little effort to assure that they're able to communicate effectively with patients. Some institutions try to provide positive outpatient experiences, but in many places they're famously awful. Residents are pressed for time or assign patients whom the faculty often don't want to see themselves. These features of the training and the greater attention given to developing procedural skills rather than effective communication promote choices of procedural careers. There's lots of potential strategies for changing the attitudes, values, and priorities and career choices of medical graduates. Here's a few. Replace pre-medical science requirements with humanities, ethics, and social sciences, as Lewis Thomas proposed years ago. You can learn all the science you need in medical school. Develop mechanisms to identify and select applicants driven by altruism, not prestige and income, and who demonstrate capacity for empathy, psychological openness, and sound moral and ethical foundations, and sustained commitment to societal well-being. Members of underserved communities should nominate medical school matriculants. Ethics, morality, social responsibility, and communication skills should comprise half of the first 2 years of the curriculum and be integrated into clinical training, which should consistently encourage psychological openness and give more weight to social context of illness and less to biological reductionism. In terms of clinical practice, medical schools are no less interested than the private sector in generating revenue, favoring good insurance, maximizing market share and profits, marketing their product lines. The health of the public is not a priority beyond the occasional lecture on social aspects of medicine. Practices are often segregated by insurance type. As with their teaching hospitals, their business plans reflect this priority of revenue generation. This is the so-called hidden curriculum, and students learn these lessons really well and grow up to emulate the practice patterns and the values of their faculty. When I entered medical school, my uncle commented that I would have a choice between figuring out how to make a lot of money or how to best serve humanity, and that on the basis of my choice, people could judge my worth as a human being. That was a provocative statement, but it was a gift, because I still ask myself if I'm doing enough. Many medical students, residents, and indeed their faculty would benefit from such provocation. Almost all medical school research funding comes from the federal government and industry, and medical schools are very interested in patents and royalties, and the priority of maximizing such funding as well as getting large grants and contracts affects hiring decisions. Social scientists and humanists don't get patents, and their grants tend to be smallish, so relatively few are hired, limiting intellectual diversity in most medical schools. Promotion is driven by funding and publication counts, and rarely is much consideration given to the importance or challenges of social and community-based research in hiring and promotion decisions. In thinking about science, it's worth considering sociologist Robert Merton's characterization of its ethos. He identified these components: universalism, it's subject to verification, anyone can contribute; communalism, the findings of science are products of collaboration and are assigned to the community. The ethos is incompatible with technology defined as private property. Disinterestedness is objectivity about the outcome. And organized skepticism, which is suspension of judgment and detached scrutiny of beliefs. Does this ethos characterize medical research today? Not entirely. Basic scientists tend to be excited about discovery, aren't educated really about societal context or social responsibilities of scientists. Since the Bayh-Dole Act passed in 1980, patents can be lucrative for scientists and their employers. Along with large grants and contracts, for some their consummation devoutly to be wished. And these priorities affect the attitudes of students towards what's important in science. Clinical research is often generously funded by industry. However, the priorities are often those of industry in those cases. Intellectual freedom may be quite limited. As for policy researchers, late translational research like myself, most tend to genuflect before the status quo in terms of healthcare organization, and few studies look at substantial transformation. Most focus on small changes in limited locales. Jess Unruh, who was a Secretary of State of California and ran unsuccessfully against Ronald Reagan for president, said that money is the mother's milk of politics. Well, it's also the mother's milk of academic research. And let's look at where the NIH dispenses its milk and start with their mission statement. To seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance life, health, lengthen life, and reduce illness and disability. These programs are designed to improve the health of the nation by conducting and supporting research in causes, diagnosis, prevention, and cure of human diseases. The NIH doesn't treat all aspects of this mission statement equally. The scientific organizations such as NIH promise imminent miracles as justification to increase their budget. And their relentless pursuit of molecular explanations affects the practice of medicine and encourages attitude towards diseases being largely asocial. It also influences public perceptions. They produce a narrow vision of what science could be, promulgating flavors of the decade to keep the money coming their way, and certainly not towards other kinds of research that might have a larger impact on the health problems of the population. When I wrote my first research project grant to NIH, it was an HIV outcome study. I got an excellent score, but it wasn't funded. I spoke to the project officer at NIAID where I submitted it. He was enthusiastic about it, but told me not to resubmit there because the director didn't consider such research to be his responsibility and directed me to what is now the Agency for Healthcare Research and Quality. So here's a breakdown of the NIH's nearly $50 billion budget in a recent year, along with that of AHRQ and the Patient Care Outcomes Research Institute. Some of the large institutes support some behavioral and health services research, but in many it fluctuates wildly from year to year. Or when a director comes in who favors basic research, support for such research dramatically decreases. Other institutes essentially never support such research. A few consistently do, but most of those that do have budgets that are less than 1% of the NIH. So can we make science more responsive to societal needs? Well, at the very least, training in social responsibility in science should be core and a substantial feature of scientific education. Revenue from inventions funded by federal grants should accrue largely to the government and not to scientists, their institutions, or corporations. Research on bringing effective care to populations should be the NIH's highest priority, and half the members of each advisory council of each NIH institute should be nominated by members of communities affected by those diseases. Government can be part of the solution, but often it's part of the problem. In the US government, they tend to avoid policies that necessitate raising taxes. They're susceptible to corporate and interest group pressures. They're reluctant to limit care and offend constituencies. They ineffectively regulate the FDA, Medicare fees, and insurance products. They overpay for procedures relative to cognitive services. Their policies promote subspecialization. And they talk about moonshots, which are mostly asocial biological approaches, rather than society-wide programs that might do more good. Are patients and their families innocent victims in all this? I think not, although many suffer the consequences, clearly, of the behavior of other actors. But just as the scientist, the clinician, the pharmaceutical company, and the health system see healthcare as a commodity, so too do many consumers. They want their share of the goods, and many, of course, would prefer not to pay for it. At 18% of GDP, who wants to work 7.5 hours a week to pay for your medical care? But they want the blood test, the scan, the bed in the ICU for their family member. And beyond that, many treat life itself as a kind of commodity, wanting more days, weeks, months of life, whatever the cost or consequences for others. There's no more thought of the common good among much of the public than among those working in the health sector. Why is that? In part, it reflects a world in which almost everything is commodified, in which autonomy is unmediated by concern about dire consequences for the health of the public, in which some people feel entitled to get whatever they want, and in which many people are not well connected to others, are replete with loneliness, insecurity, dissatisfaction with life in general, and are beaten down by the world. They come to the health care setting looking for solace, comfort, companionship, a heart that's open to them in a way that the larger world is not. Unlike those demanding care out of entitlement, who often get what they want, these individuals encounter professionals not equipped to give them what they need, and whose beliefs may be may be shaped by a government promising moonshots, a medical profession that doesn't know how to set limits, a scientific establishment that holds out the promise of conquest of disease just around the corner, lack of clarity from government about what limits are reasonable, and dogma from some religious leaders about when life begins and how it should end. Robert Bellah and his colleagues wrote a wonderful book, Habits of the Heart. They write that American individualism has become an autonomy dissociated from meaningful societal integration, damaged by destruction of subtle ties that bind people together, leaving them frightened and alone. Many abandon any notion of finding meaning in relation to society as a whole, and in the idea, in particular, of the common good. When education becomes an instrument for individual careerism, it can't provide personal meaning or civic culture. There's a fractured imbalance between individualism and communitarianism. Underlying the actions of all the actors are the values and consciousness of society as a whole outside of the health sector. Acquisition, exploitation, inequity, lack of communal concerns, mistrust, atomization, lack of fulfillment. Greed is good, poverty is weakness, decline of religion as a source of support, failure of public discourse to address these issues, and in healthcare we see this in relation to the economic and political behavior of actors and in terms of their inner lives. Healthcare is highly commodified, and health and life as well. Everyone wants a piece of the $3 trillion pie, maybe closer to 4 now. Some actors induce demand and raise prices. Others seek greater market share of people with good insurance and market products to them. Some run the till and never say no to a patient or family member. Some are interested in inventions that will enrich them, seeking royalties and consultation fees and starting companies. Patients are complicit. They want their share of the commodities of care, health, and life. All these groups push the system to do more. On the other hand, insurers, the government, and employers, each in their own ways and for their own reasons, want to limit care, its costs and coverage, in ways not necessarily consistent with optimal health. Only public sector providers and other clinics for the poor try to do the right thing, albeit with limited resources. When care is commodified, there's a disincentive to spend time talking to patients, relating to them, getting to know them, caring for them. An incentive to do more, selling people stuff, surgeries for marginal indications, excessive consultation, higher copays, costlier insurance, needless consumption of resources like ICU days, limiting others' access. There's little time and few resources to address social determinants of disease and the context in which patients experience disease and treatment, and diversion of resources from other societal needs, such as social services, education, and infrastructure, which arguably could do more for health. Can healthcare be optimized, even optimized in a commodified marketplace? Well, ethicist Edmund Pellegrino says that putting clinicians at financial risk can lead to a loss of professionalism, that market relationships rarely extend beyond the act of selling, which has grave consequences in medicine, and only the government will put public good above private interest. Economist Kenneth Arrow wrote that healthcare can't meet the conditions of a perfectly functioning market due to uncertainty about the quality of products that patients purchase. Injury to some caused by unconstrained markets may not be offset by benefit to others. Pellegrino and Callahan conclude that commodified care is inherently unjust. And among advanced economies, the relatively freewheeling market in the US for healthcare is perhaps the least efficient, while producing worse outcomes. But commodification isn't the only problem with healthcare, and addressing that, although clearly necessary, won't be sufficient. Consciousness of the actors is no less potent a force. Clinicians who enjoy doing things that are concrete and short-term, who have trouble saying no or even communicating well, aren't going to limit care and change the system's priorities. Medical schools can't help but want to be generative and train more and more specialists, nor do they know how to break with their propensity for selecting students based on a narrowly defined vision of merit rather than on the basis of capacity to care. Corporate leaders lack training, interest, or incentives to pursue societal obligations. And patients who are run down by life in our society, isolated, who need human contact, who have pain that's literal and figurative, who don't trust medical authorities from whom they're socioculturally distant, and who are confused by misinformation about what medical science has to offer, look to medicine for the healing touch. Scientists are oblivious to the societal problems, figuring things out. And politicians talk about their moonshots and certainly don't want to offend any constituencies that might drive them from office. The resulting discourse is disappointing, to say the least. Doctors selling procedures, providers, systems advertising miracles, professional societies guarding interest, educators promulgating values of the status quo, scientists making extravagant promises, corporate speech inducing demand and blocking progress, the media sensationalizing reports of scientific advances and not putting them in perspective, and rarely reporting on systemic problems. And any public intellectuals who try to balance the discourse tend to be drowned out. What you're left with is a set of relationships in which everyone is reinforcing the worst instincts in all the other groups. All of them influence one another in ways that exacerbate problems rather than solve them, and they all lose sight of the common good. So what can we do? Policy change can't be sustained when every actor wants it to fail. Number of philosophers, oh, I'm sorry, I lost my place here. I was going to briefly talk about Habermas and his theory of communicative action. He argues that solving problems depends on effective communication among these four groups: those who control capital, those who develop and implement policies, individuals and groups seeking interpersonal influence, and the values and beliefs of members of society. And in general, the capitalists and the policymakers communicate well. Other groups tend to be shut out. And in healthcare, the power does rest with capital, abetted by government and professional organizations. Without common understanding, we're faced with adversarial situations like malpractice suits, insurance denials, collection agencies, and misdirected priorities in medical education, research, and clinical programs, and poor communication in clinical encounters. And as I say, all of the groups in this context have lost sight of the common good. So Policy change can't be sustained when almost every actor wants it to fail. So these philosophers, Lukács, Korsch, Gramsci, Marcuse, and Habermas all talk about this issue. And they note that you can't just pull a policy lever and affect change without addressing consciousness, values, expectations, and so on. If not, it'll lead to failure. And in healthcare, there are all these material goods at stake and so many non-material factors that mesh with the current situation, that all the groups of actors are more inclined to bear those ills we have than fly to others that we know not of. So, is meaningful change possible? Well, all these actors are caught up in commodification. Are there issues with their consciousness? Are they involved in problematic communication? And I touched upon a lot, not all of these problems in this talk, but I believe that we need to take on a very large number of these challenges if we're going to make the kind of headway that we need to make and get the kind of system that we deserve. I think that academicians can think strategically about what they can do in their own institutions and in their own behavior, but that's not enough, because we have to solve many of these problems, and we can't ignore them all. So you may have wondered about the picture I put up at the beginning. This is The Death of Julius Caesar by Camuccini, and it represents artistically what I suggest is the situation in healthcare. So neutralizing Cassius or Brutus wouldn't have been enough. Analogous to the fervent opposition of all the actors in healthcare, everyone who greeted him in Caesar in Pompey's theater on the Ides of March wanted him to be dead. So we need to transform policy, consciousness, and communication and these power relationships. So I argue what we need is combination therapy. It's my medical analogy. Until we do that, innovations like the ACA, which of course represented a modicum of progress, are like treating lymphoma or HIV with one drug. They'll make a difference for some, but in the long run, they won't solve the problem. So can we achieve justice and equity in one sector of society alone? You can't expect all the actors to embrace an egalitarian, communitarian, ethical, non-commodified health sector when all their friends aren't doing that in other sectors of society. But we should not shy away from thinking boldly and broadly about what it will take to achieve justice for all in healthcare and society. There are many other changes that need to occur in addition to the ones I've already mentioned, and we don't have time to go through them right now. But I would say that professionals in the area have a responsibility to act both as professionals and as citizens. Silence is assent, as was written recently in a medical journal. So, just very quickly, a few of the things that ought to happen. Provide the same insurance coverage to everyone. That would be single payer. Separate is never equal in healthcare or anywhere else. And the National Academy of Medicine or someone should develop a revised set of budget priorities for the NIH that give far more emphasis to population health. In communication, limit health system advertising to promotion of public health, not their wonderful products. Stop overselling the implications of biomedical science and stop selling patients procedures that they don't need. And for patients and the public, provide the social services and the financial and psychological resources needed to address problems best dealt with in those ways. Educate patients and the public about the common good and distribution of resources. Clearer communication about the limits of what medicine can accomplish, and incorporate communities into all levels of decision making in research, education, and clinical care. So what will it take? We have to change consciousness of corporations, good luck, practitioners and consumers of healthcare, all of whom see it as a bundle of goods rather than a potential societal resource. Make it a priority to transform discourse about healthcare and relationships within it. Pursue a consensus that we're all in the same boat, and don't give up every time we fail to get there. As Rabbi Tarfon wrote 2 millennia ago, it's not your duty to finish the work, but neither are you at liberty to neglect it. Thank you.
Thank you. I have actually two questions. Do you see Canada or any other countries being a better role model with these outcomes that you want to try to achieve? And secondly, outside expanding the access of having greater, what I'm going to call general practitioners, internal medicine doctors, do you see if that were to be achieved, that that would lead to less referrals of going to a specialist one after another and result in better outcomes?
I don't think that any country has the thing nailed down, but it's worse here than in other countries, especially because costs are so high and a lot of people don't have insurance, or even those that have Medicaid. Most of you who have other forms of insurance wouldn't voluntarily switch to Medicaid because it's inferior, and a third of the doctors in the country don't take it. In terms of whether having more primary care doctors can make a difference, there's some evidence that mortality is lower in counties that have more primary care doctors. But it certainly won't solve the whole problem. And just like the student who I referred to, I mean, there is an incentive to do procedures. There was a gastroenterologist I worked with who talked about how in the old days, someone would come to a gastroenterologist and he would spend an hour, hour and a half with the patient, talking to them, examining them, looking at the x-ray films, and then decide what to do. And this was like 20 or 30 years ago he said this to me. He said, nowadays, the patient comes in and in 5 to 10 minutes you're scheduling the procedure. You know, well, and that, you know, lub-dub, right? So a lot of things need to change in order to fix these problems. Changing the incentives would be really helpful.
Hi, I grew up in a community, there was a doctor next to every home. We were sick all the time. And in New York, I go to allopathic doctors, regular doctors, but the person who really helped my asthma was a homeopathic doctor. And that's a school that is not yours, but it does exist. And to me, it's one of the methods that work. So what do you think? There's other ways of thinking about this.
Of course, I have a conflict of interest. I went to an allopathic medical school. But I will say that there are lots of situations in which just someone who cares about you can really make a big difference. And the laying on of hands can make a difference to people. But I mean, there are also certain diseases where it's actually good to get some pills or some other treatment which might affect the outcome of the disease.
Prior to COVID, there was a major effort at NYU Langone, started by Langone and Grossman. And that was to turn the hospital and the system upside down and make it patient-centric. And they hired Amazon to do that. I'm not sure what the result of that was because COVID came along. Are you familiar with that effort?
I really don't know much about it. But I think a lot of making things patient-centric at hospitals has to do with trying to increase satisfaction among patients, especially when they're hospitalized and so on. And there's certainly some effort to do that, and those efforts are worthwhile. But the fundamentals of the system aren't threatened. And Langone, like NYP, isn't building out practices where they seek to take care of large numbers of underserved patients. They're very interested in the well-insured patients, and that, I mean, that continues to be a problem. As long as there's an incentive to behave that way, a lot of these health systems are going to behave that way.
Patient-centered, but which patient?
Right.
One thing I was surprised you didn't mention, and it's, you know, is that part of the problem is that the public, I think, the general level of people are less able to understand a lot of the science. I mean, I'm a science teacher, I'm a chemist, and you mentioned pills. I talk to doctors all the time who do not even really remember their freshman chemistry course. I say, this can't be right, you know? I mean, I understand the functional groups, this is not how it works. So I'm wondering if part of that is just the level of science education and the skepticism, also about a bell-shaped curve. You know, there are going to be people on both ends. I mean, that some of the sales are successful because people don't really understand what they're being sold. And I wondered, rather than talking about just the medical schools, I think it's the high schools, a lack of, basic understanding of statistics and a basic understanding of household chemistry. And food would really start people in a much, better path. I mean, not that I disagree with what you say, but I think that it's the audience, not just what's going on. People do not understand where the disconnect is.
Well, you no doubt heard me say that I think that the science requirements should be lowered in medical school, not raised. And I think the reality is that you don't need that much scientific knowledge to practice medicine in a responsible way. You need to learn what the clinical evidence is, which isn't necessarily dependent upon knowing a lot of the basic science. But I think what doctors have is a responsibility to explain things to a patient in a way that they can understand. And Einstein said you can that if you can't explain something to, I don't know whether it was an 8 or 9-year-old, then you don't really understand it yourself. Well, doctors don't take the time to explain much of anything to anyone because they have an incentive to move people through their office, And if you're working in a clinic for a clinical corporation, if you're not seeing a patient every 15 or 20 minutes, they tell you you're not productive, right? Well, it's hard for anyone to get the information they need in that circumstance. And again, I think it should be possible to change the ways in which people practice and, address at least some of these problems.
Wait for the mic.
Yeah, her question was about midwives, and yes, I think they're often very helpful. I think they can provide equivalent care and probably in some instances better care than physicians. They may take more time. But there's certainly been studies of this that have suggested that the care with nurse practitioners, for example, is equivalent. Physician assistants are often used in lieu of having a doctor go in the room to see a patient, and that's not necessarily a positive thing. But yes, let there be a mix of practitioners. Let there be many more practitioners. Pay them a lot less. I mean, does a surgeon who doesn't do that many procedures have to be paid $500,000 or $700,000 a year? No.
Yes,
Yes, sir.
I would like to comment. Full disclosure, I'm a physician who went out of practice when the managed care came in.
Mm-hmm.
But what I'd like to say is for centuries, healthcare was between the provider and the patient. Mid-20th century, enter the insurance company, enter the administrators, and things changed dramatically. And again, with the 21st century, enter the computer and e-healthcare. So every practitioner now is looking at the computer to make sure they are clicking on every spot that they have to click on to get paid, because otherwise they can't afford to support their practice. And in addition, there are not enough physicians or even nurse practitioners. There is a shortage of technologists, of physicians, et cetera, because the cost of education is overwhelming. And the years that they go are more than perhaps most other specialties of professions.
I agree with everything you said.
Thank you.
Yes.
As I say, you've presented us with a pretty overwhelming list of issues here. Do you think there's any practical way to approach this? Does it have to be attacked one at a time, or is there somebody who could be a czar of the thing, or what?
I think we have to take on, first of all, we have to acknowledge that these are all problems. And then no one person is going to solve, I mean, maybe Donald Trump says he can solve everything, right? But I don't think any one person or even one group of people can solve them all. But there needs to be some effort to broadly address these issues, and a lot of them aren't going to be successfully addressed unless we address them more broadly in society. So I think societal change will ultimately be needed, although you can certainly make progress by giving everybody health insurance, by diminishing the incentive to do procedures instead of relating to patients and so on. So there's certainly some things that you can do, but I don't want to say that we shouldn't try to do it all. And in fact, in my book, the epilogue of the book ends with a quote from someone who says, the act of criticism, is of all the things that mutilate humankind, rests on confidence. Confidence that we certainly should solve them, and that there's the possibility we'll solve them, but it's not inevitable that we're going to solve these problems. So there's lots and lots to do. Maybe we take a.
This was very, very. Everybody has spent very minimal amount of time. You wait for the mic. Somebody would give it to me. You've spent there's been very little time spent talking about the cost of getting a medical education in the United States versus Canada or Western Europe. Yeah. And after somebody spends $500,000 and they're 30 years old before they earn a paycheck, are you surprised that they decide to go into more lucrative special? I mean, I agree that it's not right, but the cost of medical education in the United States is ridiculous.
It's quite expensive, especially in the private schools. It's less so in other schools.
Not everyone can go to it,
No. Let me finish my sentence. Cornell has guaranteed that students will graduate debt-free, but and NYU is abandoned tuition, right? Okay. I happen to be involved in a program where we do survey students on entry at Cornell, and even since they have been promised that they will graduate debt-free, when we ask to what extent will student debt influence your specialty choice, a lot of them still say that it will. Now, I think that even substantial debt, and for most students, it's not $500,000. It isn't. But for most students, debt will present a challenge for some time. But every doctor eventually is in a situation where they can live relatively comfortably. Now, maybe they're not living at quite the level of comfort that they would like to, but it can be pretty good. And so I think it's often a rationalization for the choices that people make.
One more.
I don't know if this is a fair question, but I think you did a good job of showing how many of these policy issues are embedded in larger societal kind of structures, and you talked about commodification of everything, individualism, people frightened and alone. Mm-hmm. Can you envision a scenario in which doctors become the agent of some kind of really major social transformation? Do they have the moral authority? I'm just a pie in the sky kind of question.
Well, a lot of them, the people who currently get into medical school, a lot of them don't have any interest in that regard. There are some who do and some who are very idealistic. Rudolf Virchow was a German physician who lived in the mid-19th century. And he argued that medicine is a social science and politics nothing but medicine on a grand scale. And he argued that, yes, we need to treat patients, and yes, we need to conduct research, which he did. There are some things that are named after him. But he also joined the revolutionaries on the barricades in the Friedrichstrasse in Berlin in 1848. Efforts were unsuccessful, but he tried. So I think doctors should join the struggle for a more just society. And more people should go to medical school who actually think that that's something that we need. Oh yeah, one more. Yeah, why not? I will say that there's apparently a reception later. Yes, there's a reception. And I did pass around a couple of copies of the book, which I'd like back, but there are more copies to look at the reception, so, okay.
And well, what I've been reading, another major concern is the overuse of antibiotics. And the more antibiotics used, it's also inappropriately prescribed to patients. And the more antibiotics used, then the bacteria is not going to, get affected by that. So.
Well, yeah, I mean, it's an interesting problem. I mean, and some of it is that patients come in demanding antibiotics for their symptoms, and some doctors will accede to the demands rather than spend time trying to convince the patient that they don't in fact need them. But I mean, I agree with you. There's certainly evidence that overuse of antibiotics leads to the development of more resistance, and it's a broad problem. I don't think it's all the fault of the doctors. Some of it is the perception of the public about what might be helpful to them in certain situations.
Okay, so please join me in thanking Dr. Shapiro.